Thank you everyone for joining us today for Debbie's Dream Foundation webinar. We are thrilled to welcome Dr. Emil Lou from the University of Minnesota, who will guide us through a thoughtful and myth-busting conversation about cancer care. With clarity and empathy and a dose of science, Dr. Lou will help us separate the fact from fiction and empower you with reliable information. While today's session is designed to be interactive, it differs from our town halls. Dr. Lou won't be able to comment on individual medical conditions that might come up. Still, he's here to engage in open dialogue about cautions of consulting AI like ChatGPT regarding your treatment and alternative treatments that you may encounter, and how to assess the credibility of those sources so you can make informed decisions in partnership with your medical team. Thank you also to our generous sponsors for making today's program possible. Platinum sponsor Astellas, gold sponsor Merck, bronze sponsor Arcus Biosciences and Jazz Pharmaceuticals, and friend of Debbie's Dream, Bristol Myers Squibb and Taiho Oncology. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we'll hear a presentation on, we'll hear Dr. Lou's presentation. Stomach cancer is the 5th most common type of cancer and the 3rd leading cause of death globally. In 2025, approximately 30,000 Americans will be diagnosed with cancer and nearly 11,000 will lose their lives to the disease. The overall 5-year relative survival rate is 36%, just 7% for stage 4, highlighting the urgent need for increased awareness and research. Stomach cancer also disproportionately affects minority populations, with Native American, Black, Asian, Pacific Islander, and Hispanic communities experiencing significantly higher mortality rates compared to the white population. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. She had no risk factors and only vague symptoms. At the time, she was told her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, she passed away on December 23, 2017 at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, CDF has achieved many great milestones. Our mission ambassadors provide outreach throughout the country. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We have also provided more than $2 million in research grants to date. Patient advocates come each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, the PRCRP, which allocates funds for stomach cancer research. Earlier this year in February, we traveled to Washington, D.C. with nearly 200 advocates and held about 150 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout. We hope you join us next year. Registration is on our website, and we hope that you can come with us to let Congress know that we need a cure. Dr. Emil Lou is a physician scientist and professor of medicine at the university, known for his compassionate care and deep commitment to cancer research. He specializes in gastrointestinal cancers and co-leads the Masonic Cancer Center's Molecular Tumor Board, helping personalize treatment for patients through cutting-edge science. With both an MD and PhD in advanced training from Duke and Memorial Sloan Kettering, Dr. Lou brings a rare blend of clinical insight and scientific expertise. He's also the creator of #LoopOnCancer, a social media initiative that shines a light on cancer research, patient stories, and advocacy. Through this platform, he helps make complex science more understandable and empowers patients and families with reliable information. Dr. Lou was recently honored with a research award from the Minnesota Ovarian Cancer Alliance and continues to mentor advocates through the AACR Scientist and Survivor program. We're going to make this session possible. Feel free to share your thoughts throughout the presentation in the chat section that appears on the webinar menu. The function should be at the top of your screen. Feel free to type your thoughts or questions in the chat box at any time. We will be weaving them into the conversation. Currently, you are in listen-only mode, but if you would like to join the conversation verbally and be on camera, just type in the chat feature, "I'd like to speak" in the chat, and we will bring you on as a panelist. If you prefer to listen quietly and still want to be part of the conversation, we've got you covered. In addition to the chat box, you can share your questions or thoughts using the Q&A feature. Just look for the chat icon with that question mark at the top of your screen. Again, anything that comes through, whether in chat or Q&A, will be woven into the conversation in real time. So for now, I will hand over the program to Dr. Lou. Thank you very much for being here today.
Thank you, Jen. Thank you so much for having me. And I want to make sure to start by saying thank you to you and everybody at the foundation. Please extend my gratitude, not just for this invitation, but for everything you're doing just across the spectrum of advocacy on Capitol Hill, the raising money for research, generally raising awareness through forums like this. You mentioned AACR, the American Association for Cancer Research, earlier in the conversation and introduction. That's where our conversation started with Debbie's dream and led to this webinar invitation, and hopefully a whole lot more conversations to come, and in any way we could be of help. So thank you for that. I know I'm in illustrious company. You've had many of my colleagues in the field whom I have great admiration for, other experts in GI oncology and scientists and physicians across the board. So I'm very pleased to be and happy to be in their company and honored. If you wanted, I definitely want to make this as interactive as possible. So I want to assure people, what Jen said, I'll be keeping my eyes on the chat, and certainly Jen, please feel free to interrupt me at any time if you see any of the questions or want to kick off with any questions. But when we came up with the title, Debunking Cancer Myths, I know it's something that we basically do on a daily basis in the oncology clinic. We are definitely deeply immersed in the information age, not that we weren't over the last few decades. It went from search engines, now with the emergence of artificial intelligence being at everyone's fingertips, it provides an expansion of the access to information. And really the challenge is, how do you filter out together in partnership with your physician, or if you're a caregiver, helping a loved one out, or someone you care about out through a cancer journey? How do you take a mountain of information that's available and make it relevant and tailored to what you need to have done to take care of you in the best way possible? And that's the challenge of the modern information age. And I wanted to include evidence-based oncology in the title for a few reasons, because always we try to rely on evidence, but also acknowledging that today's research leads to tomorrow's answers. So we don't always have all the answers from the medical community, but we try and do the best we can. So that's my intro, Jen. That's a way to kick it off and to invite more questions and to go from there.
Just a question just came through and I put it forth to you.
Mm-hmm. I can read it out loud. I see part of it. There we go. Is itchiness one of the side effects of losing part or all of our stomach? If so, what kind of deficiency is the cause of itchiness? That's a very specific symptom. I don't know. I don't know that maybe we'll be able to take a step back and work our way towards that very specific question. I think I was struck by the statistics. So as you said, when Debbie was diagnosed in the late 2000s, right? We've made a lot of progress since then, but we still have a whole lot more to make. But that, I think it was 7% is what you listed for stage 4 survival over a 5-year term. And so anytime that somebody has a localized form of stomach cancer, of gastric cancer, and the whole treatment strategy is intent to cure. You want to take something that's otherwise a high-risk disease, if left untreated in particular, and improve upon surgery alone. So we can definitely talk about, and many of your listeners and watchers today are very well informed, or for those of us who are new to the conversation, the centerpiece of intent to cure treatment is surgery, and then sometimes it's chemotherapy before and after, and radiation might be part of the mix based on the location of the tumor if it's slightly above the gastroesophageal junction, for example. So surgery, and not being a surgeon myself, so I'm an oncologist that more deals with chemotherapy standpoint, but as we work in multidisciplinary teams, I have a lot of familiarity with what things lead up to surgery potential success, and some of the outcomes and side effects of surgery. Whether someone's entire stomach is taken out, which is in some cases necessary, or part of the stomach. Either way, it definitely is different plumbing, as I like to tell you in lay terms. It's a different anatomy that people can take maybe weeks or even months or even years to adjust to in terms of their body, in terms of what it was before surgery and what it is after surgery for absorption of food and what outcomes they may have. I don't know about itchiness specifically. I guess I would answer that the best way I can is that knowing whether it's surgery in that part of the body or other parts of the body, one part of the healing process for the skin that overlies where the cut was made surgically is nerves grow back into that area over time. And so some people might have itchiness, some people in that skin area, some people might have burning sensations from the nerves growing. And that's my best effort to answer your question, which is highly specific, but maybe depending on how far you're out from surgery or something to show your surgeon if you have surgical follow-up might be appropriate. But thanks for your question. That's a great way to kick it off. We have another question, and I'm going to make effort to weave kind of other areas of interest that people might be thinking, and of course, don't be hesitating to put it in the chat. But if it's something I encounter daily, patients message us in or face-to-face if they're asking me, and I know many of your listeners may be asking too. I'll try and incorporate that best I can. So the question here, we know misinformation can be powerful. What's something you've seen shared that made you pause? Well, that's a very potent question. A lot, I guess, maybe globally, starting broadly. As I was kind of alluding to, there are different sources, and I try to always understand if somebody tells me, I have heard that I have to have immunotherapy. I have heard that, and fill in the blank, supplement of choice, something that's not standard, an herbal supplement, something that might be considered to be all natural, or a supplement over the counter without prescription. I've heard that will help my cancer with or instead of the treatments that you're recommending, Dr. Lou or any other doctor around the world. And so when that happens, when I see it as opportunity for conversation and for education both ways, I learn more, but also I'd like to understand, well, what is the source of information? And people might share with me that they saw a website. Some in this day and age might go to an AI source, ChatGPT or Google Gemini or others. Or other people might say, from personal experience, I know that that someone in my family had breast cancer and they underwent this therapy, which is quite different, we'll acknowledge. And then they took this. And as always, just seek to understand what someone's source is and understand where the information, before I judge whether or not I might consider misinformation, which could be subjective, of course. And I just try to tackle it best I can. So knowing how powerful misinformation can be, I think is really important. I think just educating or just gaining understanding of how much faith someone has in Google or artificial intelligence or someone else's experience, it might be very similar in that it's cancer, but it might be a different cancer. I'll just use breast cancer as a common example because many people might know someone who had breast cancer or other types of cancers. And I'll usually start by explaining that the treatment approach for that cancer is different. The cancer, the way it behaves can be quite different in terms of treatment, recurrence patterns, and so on. And so just trying to understand what is the root cause, what is the source, is one of the ways I try to overcome misinformation and just say, it's not wrong, it's just may not be tailored for your condition if you have stomach cancer or gastroesophageal junction cancer, or for the stage of cancer you have, or biomarkers, which we can certainly talk about. But what's something you've seen shared that made you pause is the other half of that question, so thank you. And I said a lot, and so trying to pick out something specifically, I would say maybe the rise or graduation from looking at Dr. Google, so to speak, which I never dissuade people from doing, but I think just understanding how to filter it, and that's where I see my role as trying to be of help to the more people using artificial intelligence to do that. And I would say also there are very openly, what some of those sources are. I went online and this was said to have evidence, and I went to a center that said I should be taking, and then sometimes it's not just one, but maybe a handful of supplements or things that are not yet proven. So that information sometimes can be hard to discuss because someone might cling, whether out of desperation or a false hope that someone else took it and may not have caused the cancer to be treated effectively. Maybe it was the treatment, the chemotherapy or immunotherapy, but regardless, there's no way to know. But it is difficult in those circumstances. That certainly gives me pause, and I always want to try and do the best I can to listen, understand where people are coming from, where they got the information from, and try to synthesize it together, and then really empower the patient best I can to make the right decision that they feel is right for them. So hopefully I answered that. I think part of debunking cancer myths is an ongoing conversation. My answer that I just gave, or that anything I might say throughout this hour, can and probably very well will be different 18 months from now, 2 years from now, definitely 5 years from now, with the immense rate of all the information we have at our fingertips, and this next level of, you have an entity called artificial intelligence that may be synthesizing for us. I'll just give maybe a funny anecdote about AI. I gave a talk last month, and it was encompassing upper GI cancers, so very much including gastric cancer, but including was charged in a very short amount of time to give an overview for an overall audience of other cancers like pancreas and others. And I experimented with ChatGPT and Google Gemini, these two tools in AI, to see what kind of script they might come up with. I did not use the script because I have the information, I'm already knowledgeable about, but I actually pushed the system to try and create a diagram, a beautiful schematic, in which it did. And then I asked the AI to label it. And what was interesting, it was completely wrong, which taught me a great lesson. I actually showed it in the slides to that audience of the risks versus benefits of using AI. It completely mislabeled and made up new names of our organs that were labeled, the stomach, and then hepatocellular carcinoma, which is liver cancer. It made up a completely different name. And it pointed to the parts of the body, and those were completely wrong as well. So that was very much an eye-opener, and it told me state of the art in early fall 2025 is go with extreme caution. That was just a very basic question I asked of AI. So I think it could probably lead to a whole lot more misinformation when actual trying to use it for clinical decision making, which I don't think is ready for prime time at this stage. So some of the questions, maybe continuing along that line, a question, thank you. Is it true that sugar or glucose is a food of cancer cells and therefore we should avoid it? Very common question. So thank you for asking. I think I think any of my colleagues who help patients with other types of cancers of any kind, I can guarantee you get the same question. I think it's particularly important to address because when we're talking about the stomach and other parts of the gastrointestinal tract that are responsible for absorbing food, nutrients, and helping us to eliminate and process toxins eventually out of the body also, these are parts of our body that are essential to that. So you can make an argument that's even more essential. I would say it's more highly complex than that. I've gained a great respect over many years, having been a biochemistry major to start, and then gone through medical school and graduate school, of just immensely how complex the tumors are, and human physiology, just our bodies are immensely complex. And there is no one thing that will lead to, in this case, destroying a cancer versus lack of success in treating a cancer. Sugar is not that one thing, but I will say more broadly, what's important to understand is, and as we can discuss more also, if anyone has questions, or I'll bring it up, young adult early onset forms of cancers, and stomach cancer is no different than colorectal and lung and other cancers, where over the last few decades we're seeing higher rates of people defined as younger than age 50. And I think that's very much part of this question about sugar, diet. I'm always in favor of a balanced diet. Our body either processes sugar that we intake if it's eaten in moderation, and it's okay. And at the same time, for example, our liver produces sugar. There's always to be a balance. We can't have zero sugar, because if sugar is too low, our body will produce it to create a fuel for our brain and our organs. So we can't exist on no sugar. But we do know that the Western diet is increasingly, over the last few decades, chock full of more fats, more sugars, and those are risk factors to getting diabetes. Diabetes, if that happens, is a known risk factor for obesity. And obesity is also a risk factor for stomach cancer and many other types of cancers as well. So it's a cycle, rather. So I would say if you consider sugar to be one factor, there's probably 99 other factors. I'm very much simplifying this, but I would say, just to underscore the magnitude, there's so many other factors at play, but it won't be as simple as eliminate sugar, therefore the cancer will shrink. But I think all things in moderation. I will use this opportunity to talk about diet and whether it's sugar, things that are sugary or high laden in fat, alcohol. Traditionally, we used to say in the 20th century that tobacco and alcohol or some combination, more so tobacco, was a risk factor for stomach cancer and many other types of cancers. But dating back over the last decade, the American Society of Clinical Oncology, or ASCO, our professional organization, and others have really come out more boldly and identified, based on evidence, based on oncology, that alcohol itself, in and of itself, is a risk factor for stomach and at least half a dozen other cancers. And either elimination or maybe more realistically, for some people, more moderation, but less frequent use and modifying alcohol intake are certainly important risk factors. So if we're talking about what we control, we put in our body, I want to introduce alcohol, that concept, so it's not so much about sugar. That said, when we get PET CTs to stage 4 cancer to understand when someone's newly diagnosed with stomach cancer, did it go far away from where it started? A PET CT, the whole principle of it is that there's a radioactive dye linked to sugar, and then a tumor takes up sugar because it's higher metabolism and a higher rate than normal organs will, and that's why it lights up. So it is hard to reconcile, even as explaining as a doctor, why a PET CT should theoretically work, but not eliminating sugar would have a profound effect on the tumor. But I think all things in moderation, and I would say, Jen and I have had this conversation, and I think exercise is the best form of nutrition. Just really emphasizing being active rather than having a sedentary lifestyle is absolutely crucial and helps for tolerating treatment better as well. So I put in I bundled a few of those things, hopefully successfully, and not too long, but I wanted to be able to address that. Thanks for that question.
I'd like to add something that comes up in any of the forums, because many people are diagnosed at stage 4. They're told that they're terminal. They're worried that these traditional treatments aren't going to help or aren't, so they're kind of desperate and they want to see what they can do to prolong their life. So we have seen in many cases they have resorted to 2 different therapies. One, Fenbin, which, if you guys don't know, it's a dog dewormer, and then the other one is ivermectin, which is a horse dewormer. So what do you think? Because of course there are social media pages all over the place that say, like, I did this to cure my cancer, and then it gets people to be worried about their own lives and then want to try this in a desperate attempt to save their lives. But what do you tell patients who feel this desperation, and how do you talk with them when they want to go about this treatment?
Right. Yeah, very crucial. No, thank you for pointing that out, because and for just openly talking about the desperation that comes with a cancer diagnosis, regardless of stage, but especially if someone is told your cancer is stage 4. You have stage 4 cancer. It's not going to be curable. The attempt is to try and manage it best we can with effective therapies and so on. And so there is an inherent, but it is especially heightened anxiety, emotional desperation, and the next logical follow through when you're in a heightened emotional state, less about logic and less about objectivity. Desperation leads one to do things and say, at the end of the day, what's the harm? And that's a lot of things that I will hear in terms of, some of the myths. And the way I think about it, and gosh, ivermectin, I did not think I would ever think of, if I had to predict 5 years ago, or maybe 10 years ago, maybe pre-COVID, what would be the top 3 supplements that people would ask about, or medications someone would ask about in cancer? I would not have predicted ivermectin, as kind of more associated with horses and parasites and treatment. But yet, how many times in the last 2.5 weeks I've had questions about ivermectin? At least 5 from patients and caregivers. So yeah, let's just put that out there. So I approach it. I'll include ivermectin, and I'll include every other herbal supplement, over-the-counter company. I won't name specific stores. Amazon, I'll name, is an online store. It's very broad. People will get it from, whether there are claims attached to it or not. And I will just comment, because it's important in the media. It's not just about AI. It's not just about Google, but social media. Those of you who have followed me or see me on social media will know I'm very active in it, and I try to provide as accurate information the best I have, and that changes over time when evidence comes out. So I will change the information that I post, and it's also about trying to combat misinformation that's out there, and also understanding. I have seen these posts, and what I would say, encourage people to read the entire of the thread or the follow-up. If someone posts an article, or especially it's an older article, person cured by taking this, shunning traditional establishment chemotherapy or immunotherapy. If you read through the thread or read the updates later, you'll find out what possible inaccuracies might have been reported, or that the person had a recurrence of their cancer. I'll just leave it at that. But it's important to kind of gather the information and just always trust but verify, I think, for any source, very much including social media as others. But globally, what I would say is a three-pronged approach. I don't tell people, no, you absolutely should not do that, or yes, go for it. I guess I would say time to pause and discuss with the patient the following. If there is a supplement of any kind, ivermectin or otherwise, that has no proof that it might not interfere with standard of care treatment, and if you were to elect to undergo chemotherapy, let's say combination chemotherapy, immunotherapy, for people who have the right biomarkers, let's say that's prescribed for a case of stage 4 cancer that's newly diagnosed, that would be a standard of care. If someone were to take ivermectin, someone were to take a supplement, how would you know? Point one would be, would you know or not know whether it might interfere with the treatment working? After first several months of treatment, the standard would be getting an imaging of some kind, a CT or a PET CT, for example. If it were to grow, I'll tell people this up front before the treatment even starts. I would say, if you were to take a supplement or elect to do that, first I would say thank you for sharing that with me, so we can have an honest and open dialogue. But if you were to do that and I'm in position of telling you the scan shows growth, then I would have difficulty interpreting it accurately as to whether or not the chemoimmunotherapy would have worked on its own, or did additional supplements interfere with it. So I think that's the first point I would bring. If you would have regret with a result like that, would that give you pause now before that you even embark upon those 3 months of treatment, or 2 months? Maybe first point. The second point might be equally as much in terms of lack of evidence. Might be we don't know what toxicity is going to occur. And I know I often hear, well, it's all natural, it must be fine, it must have no side effects. And that's not true. I want to definitely debunk that during this hour. It's one of the top 2 points I say is that milk thistle is one that comes to mind. It could cause liver inflammation, liver damage that might prevent safe administration of further standard of care, chemotherapy or immunotherapy or others, or otherwise cause toxicity, or maybe, for all we know, it could make cancer cells and tumors more aggressive. We just don't know that. So I would say that as point 2. And I would say lastly, for any, maybe less for prescribed medications for other indications, but over-the-counter, herbal, and so on, alternative supplements, whatever they're called, they often are not FDA approved in the sense that you don't know what the packaging, if what's inside the package actually matches what's being labeled on the outside in terms of the purity or otherwise what it is, even if it's bought in a store, even if it's bought online by a potentially reputable source. And I would say maybe point 3.5 might be, consider the source that might be telling you that there's evidence, and is it a person or a group that stands to profit from that desperation, Jen, that you just mentioned? If I would say, if someone's telling me this is good for anti-cancer and they're charging me a few $100s for a drug, or even like a test that would say this test predicts how well a treatment might work, just think carefully, who stands to profit from that? Is it the very people who are giving me that information? And I would say, again, trying to direct people to sources that I think might be reputable. There are 2 sources that are excellent. The Memorial Sloan Kettering Cancer Center has a website called About Herbs, and they have an excellent app you can download. If you are an Apple, you have iPhone or iPad, a beautiful app. And then also the National Cancer Institute has a very similar one. And these are very similar in that they go A through Z. You can click on any supplement of choice. I mentioned milk thistle, you go to M, you click on milk thistle. And these are really nice in that they describe in an evidence-based manner, here is what they are, here is where they're derived from as a natural product, here is the evidence behind it or not. But I would say, I think a lot of times what they are describing are research done in cells, in a dish, in a lab. It's not the same thing as a human body, which is infinitely more complex, or in animal studies, it maybe not, but I would say I don't think there's a single one looked at in randomized clinical trials in human beings for the population that we're looking at to answer the question, is this a beneficial, does this improve upon the standard of care beyond, in the example I was using as chemotherapy, immunotherapy for patients eligible. So I think that's the way I approach the challenging question of the supplements. And then I kind of circle back and say, whatever you choose to do, please let me know. So that way, if we're checking labs and for safety trying to administer therapy, if there's an explanation that possibly an herbal or other supplement may be causing that damage, we want to know what the cause might be to help you through that.
Thank you. That's all really important information. You said a couple of times when people see this information online that they need to consider the source, but when patients learn about their cancer and they do Google searches, they're just going to read what they see. And how can you help them know how to consider the source? Because you gave two great examples, the NIH website and MSK, but how can you help patients know, like, maybe this is not really a real scientific website. This is just like someone's blog or someone's opinion, or something that looks like, or maybe like a non-peer reviewed like magazine that might have some kind of random opinion on there that might not be necessarily backed with a lot of good medicine. So what are some warning signs of non-peer reviewed or not very reputable sources to help patients who might be trying to do their own research?
Absolutely, yeah. So there's a vast avalanche of information out there. So it really scans the gamut of people's comfort with like just searching the internet, just as an example, or asking questions. Some people, I always kind of ask when I'm meeting a new patient, rather than me just talking on. So what are your questions? And that gives me a sense, does someone just want to talk about what is cancer? I don't understand what cancer is. So we start more basically. And then sometimes the conversation starts way on the other end of the spectrum. Well, I searched 5 PubMed papers in the clinical trial, and they're citing to me more beautifully than I ever could some of the results of clinical trials that have led to standard treatments. And so that gives me an first understanding that where they're coming from and what they've looked at. I always like, as I said, I've been saying the source, but if people send me either an advance of visit or they have printouts, I actually really like that a lot. So sometimes, whether it's an in-person visit or the last few years, we've been able to do video visits. If people tell me, well, I went to this website, I say, great, put it in the chat, or just tell me website, let me look it up in real time. Let's go over this together now. One common aspect of this, less about misinformation, but guiding for clinical trial eligibility. The clinicaltrials.gov, gov.gov is the government's website from the National Institutes of Health for clinical trials for cancer and other things, but extremely hard to navigate. And I will tell you, a lot of doctors have a hard time navigating it too, but people will say, I'm looking for clinical trials, but I found these 10, but I have no idea what any of this information means. So that might be an effort. I always mention also cancer.net from American Society of Clinical Oncology is an excellent website that has in lay language and participation from patient advocates and advocacy organizations with experts from consensus statements translating to regular English. Again, it's an iPhone app or an iPad app that's also available. These are resources, but I always try to have patience, understanding the limited amount of time we have together, just trying to strike at the heart. Where do you want to go over your sources? How do we filter it out? Having a healthy dose of skepticism, I think, is really important. But if you go into it, believing everything you see, believing everything you hear, then it is harder sometimes to have that conversation about not trusting everything that you read. So it looks like we have let's see, another question here. So it looks like it's focusing more on diet as before. They recommend to increase our protein in our food. How much is too much, if there is such a thing? If my weight is 120 pounds, how much protein should I be consuming? That's a very specific question that I would say, maybe I will use as a jumping off point the real importance, as with many other cancers, a multidisciplinary team. So I would say your team is not only your doctor or physician assistants you might meet, not just the surgeon if you have surgery, not just a radiation oncology doctor if you have radiation. But for us, a nutritionist, we have an excellent team of nutritionists in our clinic at the University of Minnesota, and they actually help us very specifically, patients with cancers, and some of them have special expertise, and people have stomach and esophageal cancer who may have had surgery also. So I always rely on them. I think broadly I will talk about balanced diet, but for stomach cancer, what's really particular is that there's less square footage, right, for absorption. That's fluids as well as solid foods. And in the days, weeks, and months that follow, maybe even longer, that follow surgery, it can be difficult, right? It's not that someone can eat exactly the same type of food they might have been eating for many years. So adaptation is required. And I kind of, in my practice, I will go to a certain extent and speak broadly. Then I say, now I have to pass the baton to our expert nutritionists because they are really good about understanding what formulation, and maybe the best answer to your question might be seek out a nutritionist who has specialty or has seen patients like you who've had surgery for stomach cancer or similar, because that right balance, I mean, they are down to the calorie count, they are down to types of protein, the exact types of food, and they put out nice meal plans that include calorie counts. And I think that's a huge thing, whether you're trying to gain weight after surgery. But I will still come back to this notion: exercise is the best form of nutrition. Keeping active, it stimulates the appetite. Exercise moves you utilize the muscles very effectively that you can kind of more under your skin or outside your body, but it actually helps a lot with all the muscles inside your body. Your GI system, if you've had surgery for gastric cancer, how to get those muscles retrained, and it's by using the muscles like any other part of our body, and exercise is a huge part of that. So for me, it goes hand in hand. Thank you for the question.
Thank you, Dr. Lou. And another question that has come up in different forums too, because stomach cancer is very prevalent in Asia, and so they have a different approach to medicine with Eastern practices. So how would you talk to patients who might be interested in integrating Eastern medicine practices with their current treatment?
Absolutely, and really, stomach cancer, gastric cancer it sets a pattern, it sets a whole paradigm, right, for East-West and integration of ideas and increased risk. We know, especially in Korea, in North and South Korea and Japan, but really Pan-Asia, there's a particularly higher risk of stomach cancer for a variety of known and probably a variety of unknown reasons also, but equally as well in North America and Europe and the Western world as well. And some of the differences, especially in prevalence, lead to early screening. So it is standard to do screening in many Asian countries because of the high risk and high prevalence, whether or not someone in the family may have had that type of cancer. Hand in hand with that, to my knowledge, I think the gap is closed in the last decade plus, is the types of surgeries. And that, I think it started by preference, and there were more studies from the surgeons in Asia, the high profile academic surgeon community there, and some of the trials done here. For anyone, I don't want to go too much into the weeds, D2 lymphadenectomy and the type of resection, and that's something that any friendly neighborhood expert surgeon can explain much better than I can. But suffice to say, for a long time, there was even a difference in how the surgery was performed and the extent of surgery. That gap seems to have closed a lot in recent years and with design of clinical trials. But it's truly a global disease. It is for the issues known, whether it's pathogens. We talk about cancer-related pathogens. So pathogens can include bacteria, viruses, fungus. So give an example from each: H. pylori, Helicobacter pylori. So an Australian researcher won a Nobel Prize for discovering that, but inflammation in the stomach leading to a higher risk of stomach cancer. Viruses, Epstein-Barr virus, that we usually more associate with getting mono or like a common cold, or very rarely some other types of like blood-based cancers, but for that to be one of the molecular subtypes in the modern age in the last few years of stomach cancers has really come to the forefront. And in fungus, there are more studies coming out that how fungus infection has at least been associated with some stomach and other types of GI cancers. But I think at the end of the day, globally, Jen answering this question and maybe some of the others is, we talk a lot about cause and effect. There might be an association, but what's harder to say is whether something was there and is there and a cancer is found, or a cancer is found and saying strongly with evidence, which is a lot harder to say this other thing that was there caused the cancer. I talked about earlier tobacco and alcohol. I'm talking now more pathogens. Some of those stride Western and Eastern types of causes. Nitrites are things like smoked meats and other things in preparation of food have been implicated. So those are things to try and balance out, again, all moderation. But borrowing from Eastern medicine is an interesting concept. So if we're talking aside from what I said about the surgery and others, there is so much to offer that's plentiful. I mean, you're talking about thousands of years of history in Asia and other parts of the world where some of our what we consider regular treatments in cancer came from asking those questions. A great example is paclitaxel. Some people on the call may have been familiar with that. It's also used in breast cancer and traditionally many cancers, but 30 plus years ago from the Pacific yew tree is where that was discovered. And that was more Pacific Northwest of the US, but this notion that there are centuries, millennia of experience in many parts of the world, and some very legitimate cancer treatments have come through research and verification, but all started with understanding what has been known in centuries and maybe millennia in many cultures. So we have so much to learn, but trying to gather evidence in a very systematic way is part of the challenge. In 2025, no different, but maybe even the stakes are even higher where it's harder to get funding. So there's no shortage of questions, including verifying potentially the next great treatment, next day targeted or traditional treatment, and whether that's legitimate to test just becomes harder to do the research without funding dollars. And that's where Debbie's dream and so many organizations, we really rely on research funding to be able to answer those questions effectively and answer for the community. This is something that's very promising. We should do more research into this.
Thank you for that. And so like, trying to think how to word this question well. So patients who might, sorry, I'm gonna, my brain, I just completely forgot the question. So as that happened, a question came in as when you were talking about H. pylori, the question was, do people have to continue to be checked for H. pylori if they've been tested positive for it once? Is it always going to be something that they have to get tested?
Yeah, no, that's a good question. H. pylori, they call it a triple or quadruple regimen. That if someone is diagnosed with H. pylori can cause inflammation in the stomach just before getting to the cancer part of it, called gastritis. It can cause ulcers, cause a severe acid or worsening of acid reflux, and so on. So the usual combination is something to decrease an antacid to decrease acid production in the stomach, antibiotic, and so forth, that combination. Sometimes it can be followed by antibodies like blood tests to determine whether or not it's cleared from infection. If someone has been diagnosed with a cancer and H. pylori is in there, which is not too uncommon, I think I guess my understanding is it's always it's a good idea to try and treat the infection and then also begin to start treating the cancer. It depends on the oncology team about whether or not they might recheck for H. pylori at intervals if it comes up, if it's a persistent problem. It usually is associated with symptoms, and part of any course, whether someone's undergoing active cancer treatment or a history of H. pylori, if someone has persistent symptoms that are really bothersome and a doctor might question whether or not the first treatment worked, then we may have to re-examine. Sometimes that requires an endoscopy to look, and that would be a gastroenterologist who knows how to do that. I don't do endoscopies myself, but rely on them to do that. If they say this is still persistent or came back, then we should address it for patients' comfort. If for ongoing cancer, it becomes a little bit maybe different, but we always try to address that if it's causing symptoms for sure. And then also trying to do the cancer treatment safely, whatever it consists of.
Thank you for that. And as you were answering, I remembered the question I had wanted to ask in the first place. So you were asking about clinical trials before, but there are some patients, unfortunately, who have advanced disease. They're not eligible for surgery and they're not eligible for clinical trials. How can patients advocate for themselves to go through whatever palliative treatment they might be given to be safe? Because I think this would be the more vulnerable population to try alternative things that might not be safe for them.
Mm-hmm. Yeah, absolutely. Thank you. So a lot of different parts of that question, we can chew on it and go through together. Excuse me. Clinical trials. I would say my stance on clinical trials, and of course I'm biased, is that it's always appropriate to ask. Clinical trials, I always think of, it have to be a right fit for the patient, right trial, the right specific clinical trial for the right patient at the right time. So there are times of any one of those combinations, it might be the right trial for you, or the trial might be available, but it may not be the right time. And an example of not having the right time might be that you are on a treatment and it just started, and we don't yet have the answer to the question, is it effective or not? So if someone is diagnosed last month and has gotten 2 infusions, just as one example, we usually would want to have a few months of treatment before answering the question with scans, imaging, was this treatment effective? So in the middle of using a treatment, I would say, well, let's give the treatment a chance, especially if it's tried and true and has gone through clinical trials already. I think that's something also that I reinforce with folks in clinic or otherwise in saying the standard of care today was a clinical trial before. That might have been in the last year, it might have been 10 or 20 years ago, but all of it had to go through rigorous evaluation to answer the question, is this better than what we had previously? And that's how oncology builds. Of course, the progress is not fast enough for everyone the way we want it to be, but that's the progress that in 2025 that we rely on trials done in past decades. And there are ongoing trials that are seeking to move the needle further. How do we improve people's quality of life, prevent the cancer from progressing, and have people live longer, all of it at once? That's part of the intent of clinical trials. Some clinical trials are for patients who are newly diagnosed. So I would say always feel free to ask about clinical trials. If there is an opportunity to be enrolled in a clinical trial at the outset, then absolutely, that's something to be discussed, to be considered. Some centers have clinical trials only within the one center. Some clinical trials are we call multi-center across the nation, the USA in this case. And some are actually international, where, especially in stomach cancer, I would say because of the prevalence in the Eastern world that we talked about in Asian countries, some of the great trials of the last decade have been international trials that really move the needle in a big way. They allowed for integration of immunotherapy and other targeted therapies in, and that's, I would say, stomach cancer, arguably more than any other cancer. So it's always appropriate to ask, but some of the trials tend to be more for patients who have tried treatment A and it no longer works, or treatment B no longer works. There might be other treatment options, or maybe not, that are FDA approved but don't work very effectively, and that might be an optimal time for trials. Some clinical trials may be geared specifically towards stomach cancer. Some might be for stomach cancer and a bunch of other cancers, but it's based on a biomarker. And it's great that stomach cancer has finally caught up, as many other cancers, in GI cancer, where we've been envious for years of our colleagues in lung cancer and some other cancers, where the revolution that occurred was that there are biomarkers, and when there's a drug that fits that target, like a lock and key, it can shut down the machinery. Maybe it leads to some shrinkage, or for sure extending prognosis. From stage 4 lung cancer 20 years ago was weeks to months. Now it's many years people can live, and live with good quality of life. And so that's where we're on the path to stomach cancer. A large part of it is the ability to test with accuracy people's individual tumors and try to tailor for them. And the way it's graduated, it used to be, even just in a few years, not decades ago at all, would be that it's only after someone's exhausted available standard of care. And some of the clinical trials gradually moved that up to the point where for patients who are newly diagnosed, as an oncologist, the race is on when we find out the diagnosis. Make sure to get the results in time. By the time I meet with the patient, I want those results, because if someone has microsatellite unstable disease, PD-L1, markers that have implications for whether or not immunotherapy might work, or claudin, a specific type of claudin, which is responsible for cells binding together and communicating with each other, which is a special interest of mine in the lab. That's used to be an interesting finding. It used to maybe be associated with prognosis, but now it has very clear benefit. We call them predictive biomarkers, meaning predictive of a higher likelihood of success that a certain treatment would work. For PD-L1 and microsatellite instability, it's immunotherapy I'm referring to. So that ability to add on immunotherapy to chemotherapy has been proven to be significantly better for the reasons I was saying about overall survival, and we want to know that as soon as possible. So those were on clinical trials, and now it's standard of care. But clinical trials can sometimes be tricky. If you have interest in a clinical trial and it's halfway across the country or entirely across the country, something I coach people to understand is that clinical trials are very intensive. They have more oversight, probably due to more frequent labs, more imaging, more in-person visits than a routine standard of care might. And that's because of oversight. The mandate is to be able to oversee clinical trials safely. So there's a lot more visits, so that could lead to more cost financially. So we call that financial toxicity. One of my great colleagues, Dr. Gupta, here at the university, has been studying time toxicity, the amount of time patients and caregivers have to take off from work, take off from vacations, delay other plans or things they want to do outside of cancer care what to spend, whether on clinical trial or off clinical trial. And these are points to consider. But if you choose a clinical trial at a site, just think realistically, is that a place I would go if it's not somewhere where I have to go, where I live? If it's somewhere near where I live, it may require more time. Also, there are different types of clinical trials. They're usually called in phases 1, 2, and 3. Phases 2 and 3 in general are trying to prove that a promising drug might work better in addition to standard of care therapy or instead of. Phase 1 studies are often used for people who exhausted reasonable standard of care drugs, but the primary mandate of a phase 1 drug might be a new drug from the lab, something that or a new combination that hasn't been used before in this type of cancer. But the mandate for the investigators is to determine whether or not it's safe to give in human beings and determine the dose oftentimes. And of course, they also wanted to understand if it works effectively for any given group of patients, but understanding there are different phases of trials and some of the jargon, as part of the language and part of our discussion. Clinical trials are complicated. Finding the right clinical trial is complicated, but I encourage everybody to ask their physicians. And if they don't get an answer from their oncology team that they seek, then I would say a second opinion should always be welcomed and encouraged. I always encourage at my practice, if you hear the same thing that your local oncologist is saying, then maybe that's comforting. You get the reassurance you're looking for. If they say something different, in particular regarding clinical trials, then that might open up a new avenue. It's not the first oncologist did anything wrong. It just might be a new opportunity. Clinical trials open and close all the time, so right trial for the right patient at the right time. The right time may not only be for the patient, but it might be when a trial has a slot open at that center or anytime nationally. So there are a lot of moving parts. I only, when I kind of grew up, I would say, and finished my training, got deeply into clinical trials, I realized just how many hundreds of factors are always at play just for reviewing eligibility and safety and even availability for any specific given type of patient.
Thank you for that, Dr. Lou. And so for these patients who are in the thick of it right now, those who are like in the middle of their harsh treatment, and for people who are now newly diagnosed and probably getting a lot of very helpful advice from random people they haven't heard from in years and being sent random box, I know people in our community even sent random gift boxes of certain things that they heard will help cancer. What is the biggest takeaway that you want to give to people as they're going through this and navigating their care and trying to make the smartest decisions with their medical team?
Right. It's navigating cancer care, I say for many folks, is like taking on a new job, a job you don't want, right? And so it takes up time, it takes up money, and of course, pretty much all the time, you can say that the people providing the recommendations, strong or otherwise, it comes from a place of love, I think. At least, pretty much everything that I observe, I can't think of any malicious recommendation where people is trying to harm someone. It's quite the opposite. People are trying to help the very person that they love going through a difficult time, especially with a new diagnosis of cancer. I would say empowering people with knowledge is really a good starting point. When I ask what is the source, I would say I'm asking that as a doctor to a patient, but in turn, any patient can ask and has the right to question and can answer, good-naturedly, of course, of their loved one saying that, said, what evidence is there? But just kind of teaching someone what kind of questions to ask. Maybe even just starting at the basic premise of not everything is true, whether it's on the internet or otherwise, but maybe they can say, hey, thanks for that suggestion. I know you're saying that because you care about me. Thanks for the basket of alternative supplements. What proof is there behind this, and where did you hear about this? I think that's a very legitimate question, and saying if someone so chooses, for someone seeing me, I would love it if they brought the basket. I always tell people, bring every bottle of medication or any possible pill or otherwise that you want to put in your mouth or already have. Let's go through together. And I love nothing more than seeing the actual bottles. And I learn a lot, but I also understand that I would say when people lean over, like if we're sitting next to each other and they lean over, and 99% of the time I hear, I don't know, just look in the computer, doc. And I'll say, well, with unsettling certainty, the list is always wrong. It's never updated despite the clinic's best efforts and nurses' best efforts, because sometimes it's missing an over-the-counter, an herbal supplement alternative, but even the medications that are prescribed can change over time or prescribed by someone else. So I would say, actually never rely on the computer. I want to know here and now today. And of course, with a lot of medications and doses that get very confusing, I say, bring in all the bottles. And sometimes we'll look at bottles together and I say, oh, this is an interesting thing that's not prescribed. Where did this come from? And that begins a conversation. Or if the person who recommended it, whose loved one is there, then we get to have a conversation. Where did you hear about it? And I would say patients deciding on what's best for themselves and can ask friends and family who are making helpful or intended helpful suggestions. Where did you get this from? And ultimately decide for themselves whether or not they want it. Is a good start. And for me, I love it when patients and their caregivers come to the visits with me or my physician assistant team. We have an excellent supportive care, also called palliative care team. I also just wanted to mention, because that's not hospice. I understand in society the term palliative means a lot of things. Palliative means to alleviate suffering or to prevent suffering. So I send an offer, any stage stomach or other cancer, patients with cancer, 100% chance of referral from me to our palliative, or offering a palliative care referral for the idea of very proactive symptom management and care of symptoms coming from the cancer or side effects of treatment or just coping with the cancer. And I see that as yet another opportunity to go through medications, to go through understanding and help to filter out. So it's not just me, it's my physician assistant team, my nurse care coordinator, our pharmacy team helps me with that, our palliative care supportive care team. So it's very much a team approach geared towards answering those questions.
Really, thank you, Dr. Lou. This is really important information for people because, as they're going through, they're trying to do research, they're trying to do everything they can to keep themselves alive, and there's so much information out there that could be very good for them, where they can make very informed decisions with their team, but then there could be also very detrimental information that they're going to keep and try to work towards, because it's, a lot of us like the anecdotes, like this person did this and survived, and that person did this and survived, and everyone's different. Everyone's more like everyone's bodies are different and respond different to treatments and surgeries and supplements, and we all have different chemo regimens, and so or people might be on immunotherapy that might affect supplement in a way, but if someone's not on that immunotherapy, it might be fine. So there's no one answer. It's already frustrating enough that stomach cancer doesn't have a standard of care. And so, and then so to add on top of that, all these alternative things, and it overwhelms patients as they're hearing everything. And then it could be frustrating visits with doctors, because some doctors don't want the patient to go on down the rabbit hole of Google to try to find all these things. So just to help patients know how to find the best information for themselves, how to advocate for themselves, and how to work with their doctors as a team.
Absolutely.
So this is helpful, and I appreciate you. I just have a few slides to end
this.
Please. And sometimes my computer is being very slow at the moment. So just to continue on, I'm very sorry that my computer is very slow right now. But yes, so just to if there are any follow-up questions that you might have for this, please be sure to email me at programs@wstream.org, and I'll be happy to forward the questions over to Dr. Lou, because sometimes an hour is not enough time to talk about some of these really important things that are very necessary for you to go through your treatment and to feel comfortable with your treatment. So just for some upcoming events and programs, we have some programs coming up within the next couple of months. And then to finally to rethink our sponsors for their support for our virtual education program. And finally, again, really just thank you, Dr. Lou, for your time and for this conversation, and for you listening. To view any of our recorded webinars, just visit our lecture library. This webinar will be on our website within the next couple of weeks or so. But as of right now, there are no other questions that are coming through in the last minute. This does conclude our webinar, and we really appreciate you being here. Wait, I think one question came. Oh, yeah, so you're getting a lot of thank yous from our listeners. So
thank you all.
So thank you again, Dr. Lou. Thank you for everyone for being here, for your time as well, for taking time to listen to this webinar. And I hope you guys have a good rest of the day, and take good care. computer's frozen, so I'm sorry for that.
Oh, it's okay. Yeah, I was wondering if I would like. Yeah, no,
Oh, it's okay. Yeah, I was wondering.
Like I was trying to hit end seminar and
Yeah,
it
yeah,
froze, but now I
Yeah.
finally, yeah. So take care, everyone.